Hello everyone. It's very nice to have you again. Here's our fourth webinar, and I hope that you are enjoying our IDS European region webinar months so far. And today it's very special webinar since we have a very, very special guest from Turkey, Dr. Firat Selvi. I hope I pronounced your name correctly.
It's pretty good.
Thank you. First I would like to introduce myself. I'm Mariam, and I'm IDS Vice President of Science and Research, along with my favorite team, Yana Benakova. She is our school secretary. I would like to give Yana the floor to start the webinar. And before giving her the floor, I would like to thank so much Dr. Firat for accepting our invitation. Thank you so much for always trying to impact dental students worldwide. And I know it's very hard. Your time is very, very, you're very busy. So thank you so much for giving us your time and being here. Yana, the floor is yours.
Yeah, thank you, Mariam. Hello, everyone. As Mariam mentioned, my name is Yana Panachova. I'm the General Secretary of the SCORE Committee, and I would like to welcome all of you here for today's webinar. And I'm very grateful that we are here, and we can see some of the names are already, we can see them are connecting again. So also they were present yesterday. So that's we are happy to see some names are repeating and you are still staying tuned to all our webinars. So I would like to give the floor to our webinar coordinator, Ipek, so we can start. Thank you.
Hello, everyone, and welcome to the IADS Webinars Europe edition again. And today we have a very special guest from Turkey, Professor Dr. Firat Selvi from Istanbul University, Orofacial and Maxillofacial Surgery Department. And before we start, I want to thank all of the team that has put in great efforts to make this month happen, and thanks all of you to joining us today to this special series. And please do not forget to fill in the attendance form that we will be sharing in the chat box in the end in order to get your attendance certificates. And I really want to shortly introduce you to the Dr. Firat Selvi, because he has done so many great work, and he is with us today. So Dr. Firat Selvi received his dental degree from Istanbul University School of Dentistry in 2002, completed oral surgery residency and PhD concurrently at Istanbul University School of Dentistry Department of Oral and Maxillofacial Surgery in 2008, earned associate professor's degree in 2014, completed one-year clinical research fellowship at Harvard University, Massachusetts General Hospital, Department of Oral and Maxillofacial Surgery as TÜBİTAK postdoctoral scholar, successfully completed a 2-year senior level oral maxillofacial surgery residency at the same department between 2014-2016, including a 4-month rotation as a chief resident at Boston Children's Hospital, Department of Plastics and Oral Maxillofacial Surgery, became a full professor at Istanbul University School of Dentistry, Department of Oral Maxillofacial Surgery in 2022. And he is currently working as faculty and attending surgeon at Istanbul University School of Dentistry, Department of Oral Maxillofacial Surgery, pioneered lingual nerve microsurgical primary repair in Turkey, and introduced patient-specific custom-made subperiosteal jaw implants. Academic interests include nerve injuries, orthognathic surgery, trauma, implantology, kits and tumors, and impacted teeth management. Regularly contributes to national and international publications and serves as an educator and invited speaker at scientific events. So after all that, I am really, really excited to listen about today's topic, and I want to yield the floor to him, and let's start. Hope you all enjoy.
Thank you, guys. First of all, I would be mentioning a lot of thanks to many people here, especially the International Association of Dental Students and the organizing committee for preparing all these seminars, webinars. that are really helpful for all the dental students all around the world. And I'm honored to be a part of this webinar today. And hopefully I'll be talking about an interesting topic, which is indeed, as you can understand from the title, it's a life-changing operation, orthognathic surgery. So hopefully it won't be too boring for many of you, even though you're not very interested in oral surgery maybe. But I will be going through the basics of orthognathic surgery, and I'll explain how we do these operations, why do we do these operations, and what kind of results we get out of these operations. So let's go to our first slide. A poor surgeon hurts one person at a time, but a poor educator, a poor teacher hurts many more. So that's why I'm really excited to share all my knowledge with dental students, because as we educators, if we do, educate our young colleagues well enough, then we will be benefiting a lot of more patients at a time. So that's very important in our careers. As you all mentioned, I'm a graduate of Istanbul University School of Dentistry. I also did my oral surgery training over there. And then I had the privilege of attending 1 year of clinical research fellowship, and then 2 more years of senior level OMFS residency at Mass General Hospital, where I had a huge exposure to orthognathic surgery. And that's where my first clinical interest started on orthognathic surgery. Later on, I also had the advantage of attending Boston Children's Hospital for 4 months as a rotating chief resident. And I was over there. I was also lucky to see a lot of pediatric patients and patients in the need of craniofacial surgeries, which are also included in the orthognathic surgery setup. This is a photo from 2016. These were my teammates. And what is exciting about this photo is that I was able to work with a lot of different cultures and different countries. I had American friends, I had Korean friends, I had friends from all over the world, from Iran to Puerto Rico, from China. So that was a very lovely experience for me. And I would encourage all the dental students here listening to this webinar to do an international work like this in their careers. So before going on to my next slides, I have to mention a couple of names here. These are all really valuable professors that I had the privilege of working with. Dr. Caban was our chief at the Mass General Hospital Oral and Maxillofacial Surgery Department when I was a research fellow, and he's a big name in orthognathic surgery. But I also had learned so much from Dr. Padva at Boston Children's Hospital. And I also had the privilege of getting to know Dr. Alice from San Antonio, Dr. Reineke from South Africa, who has a huge textbook, and also Dr. Posnick, who's also a MGH graduate, who also has a very actively known and used textbook on orthognathic surgery. So moving on, I would like to mention why and how this orthognathic surgery came up to the interest of humankind. It comes from ancient Greek words, orthos and gnothos, meaning straight jaws. So from even in the very old times, people were always trying to figure out ways to correct the dentofacial deformities. And they did a lot of operations, and they tried a lot of different techniques to overcome this problem. And in time, oral and maxillofacial surgery evolved. Plastics and also ear, nose, and throat surgeons were also interested in this topic. And they all had different styles and different techniques, but they all led to today's contemporary oral and maxillofacial surgery practice. And these operations became standardized all over the world. I would say why oral and maxillofacial surgery is the most competent of all of these subspecialties. Well, because we know occlusion and dental details way better than most of the other specialties, because we are dentists to begin with. And then we also know the temporomandibular joint a lot better than many of the other medical specialties. So I personally believe we are really competent in orthognathic surgery because of this. Before going on to the details of orthognathic surgery, first we have to understand the fundamentals of facial aesthetics. As I said, even from the early times, people always try to reach the golden ratios in many ways, and in time, people start to look at things differently, and measurements and dimensions and proportions became important to people's eyes. And aesthetics and beauty norms changed a little over time, but in general, the general rules stay the same. Beauty, as we all know, starts with a beautiful smile. So if you have a beautiful smile, people will notice this as the first thing when they encounter with one another. So our major goal is to create a beautiful smile in orthognathic surgery. Of course, we are living in a social media world, and especially all you guys, young colleagues, are much better than most of us my age regarding the social media use. But this social media world also led to the idea of being in a world where we live in aesthetic madness, I would say. And people start to care about their outlook so much, way more than before. And in these different photos, you see different people with all similar facial appearances. And what's noticeable is that all of them have a beautiful smile. So their proportions are very important in the face and the dental relationships. And even though you go to different world areas in the world, if you go to different areas in the world, you will see a lot of ethnic and racial differences. But as you can imagine, all of them have their own beauties laying besides them. However, the most common thing is, as you always notice, is the smile. So here you see different races, and the most common thing is the beautiful smile with a lot of teeth showing. A youthful smile is considered a gold standard for aesthetics. Of course, there will be racial differences. For example, the Caucasian race will have a more straight profile, whereas in the African American population, the bimaxillary protrusion is considered normal. And when you go to the Far East Asia, then you will see more flat faces, and the concave profiles could be considered normal racial appearance, whereas they would look much more deficient on a Caucasian or a African American community. But in general, we can say a straight facial profile is the most desirable profile within today's world. And in female, characteristics are a little different than the male characteristics. In females, we like more rounder facial contours, more fuller lips, and less prominent chin projections. So like a little bit of class 2 patients, if they're females, are considered more beautiful than straight profiled females. Whereas in males, an angular facial contours, more prominent zygomatic bones, a more prominent jawline, and a chin projection is more desired compared to females. But of course, there are always exceptions to every rule. As you can see here, Tom Cruise, a very famous, world famous actor, he has a huge midline shift on the maxilla, but he is still looking stunning. Also, Madonna has a huge diastema, which she wore for years, and everyone was enjoying it. And of course, Julia Roberts, which is one of my favorite actresses, she has a huge smile with a lot of gingival show. We would say a gummy smile, which doesn't look bad at all. So what are the main goals of orthognathic surgery here? Well, the first thing that we need to deal with is occlusion, okay? We need to maintain a functional and reproducible occlusion following orthognathic surgery. So that's the most important thing. Besides that, we also have to have a good harmony in between temporomandibular joint, teeth, and muscles, okay? Because this will lead to resolving temporomandibular disease at some point. Facial proportions are very important to us, and we would like to improve those facial proportions with this orthognathic surgery. Airway, that's also a crucial thing for life. If we increase the volume of the posterior airway, we can treat obstructive sleep apnea permanently. So that's the best way to solve the obstructive sleep apnea symptoms, orthognathic surgery, BIMAX advancements. Phonation, as you can imagine, tongue has to have enough volume inside the mouth. And if the patient has a deficiency, either mandibular or a maxillary deficiency, and if one of the jaws or both of the jaws are smaller in size than usual, then there's less space for the tongue. So the phonation usually lisps and all these kind of phonation difficulties arise because of these dentofacial deformities. Oral hygiene, of course, if there's a small chin, if there's a small jaw and if there are big teeth, then there will be crowding, and of course that will, be a negative risk factor for oral hygiene. Psychiatric status is very important in patients in everyone's lives. When you correct the dentofacial deformity of a patient, you also touch the lives of these patients, and their self-confidence dramatically increases, and that's why I call this operation a life-changing operation. And of course, finally, the last but not the least, aesthetics. We would like to improve the facial aesthetics, achieve patients' aesthetic expectations, and make them a better person, a happier person in the long run. All right, so since we have a lot of different dental students attending this webinar, we need to talk about different occlusion types. Maybe there are very young colleagues, future colleagues within this webinar. So when you look at the occlusion types, we have to know that class 1 occlusion here is the desired occlusion that we want to achieve. Sometimes the lower jaw is way further back compared to the upper jaw, and those patients are called class 2 occlusion, having a class 2 occlusion. And also, if the lower jaw is protrusive compared to the upper jaw, then the patient is said to have a class 3 occlusion. The ideal overbite and overjet ratio is also something that we need to be aware of. The ideal overbite and overjet relationships are as listed here. We would like to achieve these at the end of the operations. So dental crowding. What do we do when we have dental crowding? Well, orthodontics is the specialty of dentistry that deals with dental crowding to solve dental crowding issues. And in many of the cases, if there is no skeletal discrepancy in between the two jaws, our orthodontic friends can, as you can see here, can overcome the problem without a surgery, and they can line up the teeth in the arch bars, in the arches, and without a surgery, the problem can be resolved. But what if there's also a dentofacial anomaly? Like in this case, the patient is considered a class 3 patient, and as you can see here, the lower jaw is massive compared to the upper jaw. And intraorally, there's also a severe dental discrepancy. As you can see here, the patient is only occluding with only a single tooth, and the upper jaw is so narrow compared to the lower jaw. Another class 3 patient, besides being deficient in the upper and lower jaws, the patient also has an asymmetry when looking from the frontal aspect of the patient. So a lot of combination of problems together, and this is a severe dental and skeletal discrepancy. As you can see here, the patient has over negative 16 millimeters of negative overjet. So this cannot be corrected with solely orthodontic treatment. So we definitely need to operate on these patients to benefit for the best results. And as you can see here, the class 3 patients, lateral cephalometric X-rays and the Panoraxes showing only one tooth occluding, and how the skeletal discrepancy is, how severe is this dental and jaw discrepancies. Here's another example of a class 2 patient, just the opposite. Now the lower jaw is very small compared to the upper jaw. So these patients usually have airway obstructive problems too, besides just aesthetics. So as such, which patients are good candidates for us in orthognathic surgery? So that's a question that we need to ask to ourselves when we see a patient who is in the need of orthognathic surgery. So as I mentioned, class 2 malocclusion, which is also known as bird face deformities in the literature, or overbite patients, are good candidates for orthognathic surgery. These patients tend to move their chin up, move their heads up, so that their chin point projection is more prominent, looking more prominent, as you can see on these photos. Or male patients, they usually grow beards, because that would camouflage the deficiency in the chin area. So that's an advantage for guys. But there is one specific thing that you will see in most of these patients, which is the mentalis muscles overworking and trying to compensate the deficiency, which is called the mentalis strain. Okay, so this is a very common clinical finding that we see in retrognathia, oral incompetence, and vertical growth. So if we correct the dentofacial deformity, this mentalis strain usually disappears. After class 2 patients, class 3 malocclusion cases are also called underbites, are also good candidates for orthognathic surgery. In the center photo, you see Joaquin Phoenix, who is a famous actor, with a cleft jaw, upper jaw, and most of the cleft patients usually have deficiencies in their maxillas, in their upper jaws, and that deficiency usually leads to a class 3 deformity. But overall, laterognathia or facial asymmetry cases are the cases that really usually comes to us straight away without any questions, and they're willing to get this orthognathic surgery operations without asking too many questions. Why? Because patients usually see their faces in the mirror every single morning, every single day, in every moment that they look into a mirror. So some of the cases, when they look at from the lateral aspect, they don't see the deformity that much. But when you have an asymmetry in the face, that's something that really bothers patients. Speaking of asymmetry or symmetry, do we really want to have the symmetry always perfectly? That's a good question that we need to ask ourselves. Well, the answer is no. Because when you look at these demonstrations, they have mirror imaged the right side of these beautiful people and matched it with the left side. And as you can see in these photos, none of these profiles, facial profiles, are better than the originals, right? Let's check out the left ones. You see, they're not better than the right side. So the natural beauty comes from a little bit of asymmetry. I have tried this myself, and it didn't work. Hopefully it didn't work. So gummy smile is also something that we need to consider in orthognathic surgery. But gummy smile does not necessarily always mean a vertical maxillary access, okay? An excessive gingival show could be due to a lot of different things. So in vertical maxillary access, there's most of the time gummy smile, but every gummy smile does not mean vertical maxillary access skeletally. So let's look at the other options. For example, the levator labii muscles could be working too much. Excessive working of these muscles may cause a gummy smile. So if you do a Botox injection to these Yonsei points, the smile goes back to normal, okay? So you can treat these without a surgical intervention. Also, if the vertical dimension of the teeth are very short, then we can do a gingivectomy and open up the gums a little more, and that will also decrease the amount of gingival show. So that's also a good option to treat these patients. How about this option? VY. This is called a VY lip lipplasty, where you can change the shape of the lip with a surgical intervention and without touching the bony tissues at all, okay? And the last option here, as you can see, is the gummy smile correction using a modified lip repositioning technique. So all of these different techniques can successfully overcome the gummy smile issue. All right, anterior open bite is also something, is also another deficiency that is also important in orthognathic surgery outcomes. So you probably know this profile, right? If you don't, maybe guys will know more than the girls within the audience. This is a very famous soccer player who has an open bite, anterior open bite. And also there's also another person that we all are familiar with, the former First Lady of the United States. They all have the same problem of having anterior open bite, where there's a anterior open bite and they only occlude on the posterior teeth. The reason behind this is usually an excessive excessive amount of baby bottle sucking in children, or later they can continue this habit with thumb sucking, and the premaxilla then opens up and grows in a pattern where there's a anterior open bite. Another important issue is the transverse discrepancy, as Michael Phelps says, where the maxilla is very narrow compared to the mandible. Obstructive sleep apnea patients, as we all know, Shaquille O'Neal, he's a big guy with a short neck, and now after quitting active sports, now he has gained a lot of weight, and now he is suffering from obstructive sleep apnea, okay? And the best way to treat this is, as I have mentioned, Bimax advancement of these cases, and genial tubercle advancement as well in some cases. So there are a lot of literature out there that you can read over showing how the posterior airway changes in these severe sleep apnea patients when they get the orthognathic surgery, Bimax advancements. And as you see in these clinical photos, in these radiographic photos, how wide the posterior airway becomes after these operations. And here, that's also a demonstration. So we do 3D movements in space. We can do all different types of movements using the orthognathic surgery. Once we mobilize the maxilla and the mandible, we can move it sideways, we can move it up and down, we can move it and in a different, all 3 dimensions. And we call these pitch, yaw, and roll movements, okay? And we use these for advancements, for setbacks, for impactions, for shifting or elongation. When we talk about roll, we can correct the cant by doing this. For midlines, we use the yaw correction, and for the tooth show differences vertically, we use the pitch. So so far, we talked about the indications for orthognathic surgery, but there's also contraindications for every procedure we do. And the most important one is, I don't know if you have ever heard of the word dysmorphophobia, but it's basically called the body dysmorphic disorder. So the patient does not like some parts of their body at all times. And you cannot really help these patients. Even if you do the best operations, they would still be not happy with their results. So those patients need to be really avoided for orthognathic surgery, because they will not be happy at the end. So what we do for a preoperative preparation towards the orthognathic surgery? Well, initial analyses are very important. We have to listen and understand the patient's major chief complaints. Most of the surgeons do not do this. You have to listen to your patients, because what you want to do may be a little different than what the patient expects, okay? So you have to listen to them and see what their major chief complaint is. And then you have to evaluate the clinical and radiological findings and perform skeletal and dental analyses using cephalometric evaluations. And then you have to go ahead and obtain extraoral and intraoral clinical photos. And sometimes when you're looking at the patient, everything looks good. But when you take clinical photos and check out the clinical photos on the computer, then you can sometimes see slight asymmetries or slight deficiencies that you were not aware of just by looking at the patient. Okay, so that's very important. And you have to compare the patient's expectations versus reality, because sometimes you do the best operation and the patient is expecting something way different than you're actually wanting them to get. So you have to understand patients' expectations and to see if they match with reality. And of course, we have to inform the patient regarding the complication risks and possible outcomes. I mean, sometimes we run into problems, and every operation has its own risk factors associated with it. So you have to really go through all these complication risks and make the patient understand all of these. Orthodontists and surgeons' harmony is a must in orthognathic surgery. If the orthodontist does not understand what the surgeon is talking about, or vice versa, then the patient will not have a good result at the end. Okay, so that's a must. And following all of these steps, then we will go ahead to the preoperative orthodontic treatments, which usually, and within this preoperative period, you have to, as a surgeon, you have to evaluate the patient every 3 to 4 months to see if the orthodontist is really doing the thing that you are thinking about that orthodontist being doing. So those needs to be matching to one another. And then we have to prepare the patient for the upcoming surgery by checking out every detail during this preoperative assessments. All right, so now I will go through a sample case with you for you to understand how detailed work is orthognathic surgery preparation is. Excuse me. This is a patient that comes to the orthodontics clinic, and the chief complaint is, I have crowded teeth. Well, what do? First, you go through the past medical history of the patient, past dental history of the patient, habits. Do they smoke? Do they use drugs? Or do they have bad habits like, thumb sucking, etc.? Do they have any medications that they are on? Do they have any allergies? Or how is their oral hygiene? Because like with a terrible hygiene, you cannot do an orthodontic surgery on these patients. If you do these operations on a terrible oral hygiene, then infection risk really rises up. So you have to be careful about these. And patients' motivation is also very important. If they believe on what you're proposing to do for them, then you're on the right track. Temporomandibular joint exam is very important as well, because sometimes these patients having dentofacial deformities have temporomandibular disorders to a point, to an extent. And CRCO shift is also very important, because if the patient does not have a reproducible occlusion to begin with, then you have to really be careful about these patients. So the soft tissue analysis is very important too. Not only the bones, but the soft tissue analysis is very important, and there are guidelines that we have to follow when checking out these proportions. And as you see here, different vertical and horizontal proportions are listed to our knowledge. In the transverse dimensions, we look at the facial form, we look at the midline, we look at the chin point, We look at the nose tip being deviated or to be on with the face, mentalis strain, etc. Excuse me, and all different things in the transverse dimensions. And then we move on to the sagittal plane. And the sagittal plane, we do check out a lot of different things. We check out the type of the profile. As you see here, for this patient, it's a convex profile. And then we go through the nasolabial angle, mentolabial sulcus being deep, and also cervical mental angle. That's also very important. And the chin to throat distance should also be checked out to be either short or long. What else? Aesthetic facial angles. There are a lot of different literature out there that lists a lot of different angles for us to control, to take action in orthognathic surgery, and these are some of those angles. We have to make sure the lips are competent at the end of our procedures. So that's also very important. And how do we evaluate these? We use the Ricketts E-line and Burstone analyses for the lips incompetency. And of course, chin point is also very important in the projection of the profile. Well, we also have facial thirds, as we mentioned, the upper face, the mid face, and the lower face. And we need to look at the proportions of those to one another and also within themselves. Then we have to evaluate the smile, because every patient has a different and unique smile. So we have to look at the smile arc. We have to see how much the gingival show is, the gingival display is, and the maxillary and the mandibular midlines, if they're on with the face or not. Then we come up to the skeletal analysis. And we check out the panorex of the patient for the ramus condyle units in the vertical dimension, if one is asymmetric compared to the other. If one is short, one is long, then there will be a cant in these patients, or if the temporomandibular joints have different shapes and the midline are not on with one another. These are all things to be checked out. And PA cephalometric x-rays, these are very important for us to evaluate the cants, the asymmetries, upper and lower jaw asymmetries especially. And with the lateral cephalometric x-ray, which is a golden standard for us, it's a must-have x-ray in orthognathic surgery. Why? Because we do the cephalometric analyses. We use specific points, anatomical points, which are all very important to us in evaluating a patient's skeletal deformity. And then we come up with a summary of these analyses, and then we move on to the dental analysis. So we look at the two jaws differently. One, we look at the narrowness, the shape of the arch, the crowding within the jaws, within the arches. All of these things are very important. And then we take photographs from frontal, right buccal, left buccal, and see what the issues are going on over here. And there's the Bolton analysis. Bolton analysis is analysis being done to measure the width of each teeth, the dimensions of the teeth sizes, and to see if there are discrepancies in between one another. So after gathering all these data, overall status is obtained, okay? And then we come up with a problem list. And then we come up with our objectives, right? So we list our problem list, we list our skeletal problem list, we list our dental problem list, and our objectives in the treatment. And then finally, we come up with a treatment plan. As you can see, until now, everything was so difficult and long lasting, right? So we spent so much time in those analyses. So when you do the incision, until the incision, you do a lot of work before going to that operation. So you come up with an ideal treatment plan. You expose this to the patient. and see and the cephalometric analyses. You can tell about which part of the jaw goes where in the anterior posterior direction, in the vertical dimension, or in the asymmetry sidewise. So you go through these with the patient, and then you show the patient a surgical projection of the outcome, possible outcomes that you plan to do with different treatment options, and see if the patient's expectations meet with your treatment options. Okay. If the patient doesn't like the first plan, then you go and do the alternative treatment plans, staying within the scientific limits, of course. So when the patient agrees with your treatment plan, then everything starts. So pre-surgical orthodontic treatment, you try to decompensate the angulations of the teeth in the arches, and you have to do the leveling for each teeth, and then you do the alignment of the teeth on each dental arch separately than the opposite jaw. This is very important because you have to tell about this to your patients, because patients usually do not think about the process of the whole treatment plan, but they just care about the outcome. So during the pre-surgical orthodontics, usually the things get worse intraorally and facially. Like in this case, a class 3 patient, they usually, when we do the decompensation, the mandibular teeth are proclined and the anterior teeth are retroclined. So the deficiency gets worse. So you have to mention this to your patients, otherwise they would be scared about being lost during the treatment. Sometimes we might have biplanar occlusions, and sometimes we need to correct that orthodontically prior to going to the operation so that we can do the operation easier. And then I usually do virtual surgical planning nowadays for my double jaw cases, because it's a very precise surgical planning, and orthodontist, surgeon, and the patient, all of these three people have to agree on the VSP. And then you talk about the anesthesia risks with the anesthesiologist in the pre-surgical preparation. And then, of course, you have to go through a really important consent form. And otherwise, on the long run, you might, end up with problems with your patients. In the virtual surgical planning in VSP, as you can see here, we can do whatever we want. In 3D, we can play with each jaw and see what fits and what really answers the problems to the patients, that specific patient's deformity. Okay, so we do a lot of different planning with these surgical plannings. From now on, I will show a lot of patient photos. So I would appreciate if you do not take photographs or videos, or expose these to other third parties, but just for educational purposes, just listen and try to understand what I'm trying to do. Here's a sample case, a very pleasant young lady who came to us because with the chief complaint of a significant cant in both the maxilla and the mandible that was disturbing her in her social life. As you can see here, she has a little bit of vertical dystopia as well, but otherwise she was healthy. So to solve her chief complaint of significant cant, we had to make sure if that cant was not only in one jaw or two jaws, but or in the soft tissues, but skeletally, if it was really the case. And using a PA cephalometric X-ray, we could tell that there's a significant cant in the skeletal basis as well. She was on the lateral clinical photos, as seen here. She's bimax retrognatic, meaning both jaws were farther back than they should have been, and also she had a nasal dorsal hump, most likely due to the retrognathia of the upper jaw. Excuse me. This is the lateral cephalometric X-ray demonstrating the BIMAX retrognatism here. So we get the cone beam CT of the patient, where we can do a 3D recon of the skull and see these deformities more clearly in 3 dimensions. So using the virtual surgical planning, we were able to overcome the cant correction. We could do the treatment of cant correction in the facial aspect, and also on the lateral aspect, we would do a counterclockwise rotation and BIMAX advancement for this patient. And these are her numbers. We don't treat numbers, we treat patients. So these numbers do not always mean that they are the best solutions to these patients. So we have to make sure that these numbers are somewhat in the norms, within the norms. But the most important thing is the clinical status of the patient. So we go through the premature contacts and gaps evaluation. We can look for a lot of different things here. We can measure the distances between the proximal and distal segments of the patient in the mandibular osteotomy. We can even know the premature occlusal contact points using these 3D simulations in the virtual surgical planning. And of course, we have to check out the inferior alveolar nerve while doing a BSSO operation. Finally, we can come up with a treatment plan, and using this treatment plan, we can show the patient how the soft tissue projections will likely be happening after the operation, and see if the patient likes those. So, going into the other details, we come to the operation day. Okay, in the operative room, we usually work with hypotensive general anesthesia, and we do our markings. We give the patient antibiotic, corticosteroid applications, local anesthesia, blah blah. We do everything as needed, and then we go with the operation. So the prep and draping of the patient is very important. We have to see the whole face and the ears as well to see if the proportions are visible at all times. And we use a good nasotracheal intubation tubes so that the patient's nose is not anatomically affected with it. These are the measurements that we do before the operation, so that we record everything. So in the vertical dimensions, we usually place a screw here. I usually don't like to put screws on that nasion, so I usually use a skeletal landmark after I do my incisions, but different surgeons choose different options for recording these pre-op measurements. So we go on to the upper jaw osteotomy, upper jaw surgery first. So in this demonstration, as you can see here, the maxilla is completely detached from the skull with the 41 osteotomy, mobilized from the skull base. And I will show you how we do this operation. This is the incision. The whole incision is done intraorally from the first molar to the extent to the other molar, to the first molar on the contralateral side. And then we raise a mucoperiosteal flap all the way almost to the inferior orbital nerves. And then we have to dissect the nasal mucosa off the maxilla, okay? And when we are doing this, we use a freer elevator because it's not sharp and it doesn't lacerate the mucosas. Then we have to we have to make a cut to the nasal septum, and we have to elevate the nasal septum and detach it from the maxilla, okay? In order to do this, we start with a nasal gouge, as you can see here, and then we move on to the double ball osteotome, or Albrigheiser type nasal osteotome, and we tap and cut the nasal septum all the way to the posterior nasal spine. And using a malleable retractor, we protect the lateral nasal mucosas, and we mark the osteotomy line for the maxilla, okay? And using an oscillating saw, surgical saw, or a piezo instrument, you start doing the osteotomies here, okay? And you have to be very delicate and very patient while doing this because the anterior sinus wall is very thin, and sometimes you might end up with some cracks in those areas. Once you're done with those, next thing that you need to do is to separate the lateral nasal walls, okay? And this is done using a lateral nasal osteotome. It's a guarded osteotome because you protect the nasal wall, the mucosa. And while we are doing this, you have to reach all the way farther back where the descending palatine artery is located, okay? When you come to that area, the noise of the osteotome changes, and you understand that you're on the thick area of the bone, so you stop there to prevent excessive bleeding. Once you separate those, next thing is separating the pterygoid plates, because those are the only bony segments left prior to your down fracturing of the maxilla from the skull base. And in order to do this, you have to use pterygoid osteotomes, okay? So I'll show you the demonstration of a pterygoid osteotome, and you go on the posterior aspect of the maxilla, and you try to separate the pterygoid plates from the maxilla, okay? We, on the other hand, use a different instrument here, Smith pterygoid osteotome, and we find it very useful because of the ergonomy of the instrument, and it's very useful in our separation of the pterygoid plates. While doing this, the most important thing is to go from above to the bottom. So from superior to inferior. Never go from lower to higher up. Why? Now you will see why. Because on the posterior aspect of the maxilla, there's this internal maxillary artery, and you can end up in a huge, significant bleeding, and that's the most scary thing that you can end up in a Lefort 1 osteotomy, okay? So that's why we do the pterygoid fractures last, because if you run into a bleeding, then we have to quickly down fracture the maxilla and reach the posterior aspect of the maxilla and pack those areas and get some help. At the end, the maxilla is mobilized from the skull base completely within the bony segments. So at this point, with your finger pressure, you should be able to down fracture the maxilla. Sometimes it's not that easy, so you can use a bone hook like this. And then once that bone hook helps a little down fracture, then you can use different instruments such as Smith spreaders or raw V forceps to completely mobilize the maxilla from the skull base. Now I'll show you a video of mobilization of the maxilla. Raw V forceps, as you can see here, are placed on both sides of the maxilla, and you can move them in 3 dimensions and check out if the maxilla is completely mobilized from the skull base. Next, you can use pterygoid lifts to pull the maxilla forward and to elongate the mucosa on the posterior mucosa to extend to be flexible, so that you can have a movement without any pressure over there. And then once that is completed, I usually place a wire here to the intranasal spine after drilling a hole into the intranasal spine, and see if the maxilla is freely mobile without any bony interferences. This is something that we need to achieve to prevent a relapse. Once we are happy with the mobilization of the maxilla, then we use a surgical splint that we have prepared previously to our intermediate splint if you are doing a double jaw, or a final splint if you are doing a single jaw operation. And then we do an intermaxillary fixation. And then we do our measurements again and see where we need to place the maxilla exactly. And then we have to check out the teeth show, okay? Once we are happy with everything, then we can go ahead and plate the maxilla and fixate it. And for the fixation, I usually like the pre-bent Lefort plates instead of these regular plates because they are much more easier to apply, and also they're stronger as compared to the regular plates on the long term, since they don't have metal tiredness when you're trying to bend them back and forth to give the best shape. And these are application of those pre-bent Lefort plates. For example, here we have moved the maxilla 5 millimeters on the left side and probably 5 millimeters on the right side. So we used those pre-bent plates. And once we are happy with those, then we use a Euler cinch suture to prevent widening of the Euler base. That's very important. And we do these using a resorbable suture that holds the muscles together and prevents the nasal Euler nasal base to be widened at the end of the surgery, because we move all the soft tissues along with the maxilla forward, and that causes a little bit of elongation in the nasal area. Once we are happy with all of those, then we go to primary suturing of the wounds. Tie a suture like you embrace the one you love, firmly but tenderly. All right, if we are all happy with the Lefort 1 operation, if we are comfortable with the Lefort 1 operation, let's move on to the surgically assisted rapid palatal expansion operation, which is pretty much the same thing with the Lefort 1 osteotomy. What is different? We do an additional osteotomy in the midline. This is an operation that we perform for the maxillas, which are narrow, a lot narrow than the mandibles. So if there's crowding and if the arches are very narrow like this case, then we can either use two distractors. One, a bone-borne distractor, which is more expensive, or we can use a tooth-borne appliance, the palatal distractor, which usually the orthodontist fabricates for you and gives you prior to the operation. They both have holes and the key that you put into the hole, and the patient moves them every day so that it expands the maxilla into. As you see here, the osteotomies are completed as a regular Lefort 1 osteotomy, including the pterygoid plates, and then a midline osteotomy is usually performed using a piezo surgery. And at the end of the operation, we use an osteotome to check if the midline diastema is arising here after the midline osteotomy, because that's the most important thing of all. Then we place the appliance, and the patient is advised to turn this key every day. And at the end of a couple of weeks, the patient ends up with a diastema in the midline, in the facial midline, which will help us to move the crowded teeth in place orthodontically in a couple of months. Okay, so using this technique, as you see in these clinical photos, a nicely angled arch is obtained. And from a narrow face, the patient ends up with a beautiful, more proportionate facial aspect. Okay, so let's move on to the mandibular osteotomy. And I hope you're not tired to listen to me, or if the topic is still interesting for all of you guys. For the mandibular osteotomies, there are a lot of different techniques, but the most commonly used one is the bilateral sagittal split osteotomy, which consists of an osteotomy on the left and right side of the posterior mandible that basically dissects mandible into three pieces, two proximal segments and one distal segment. The incision is all intraoral, unless you're going to use a trocar incision for placing 3 bicortical screws. And basically, this is the operations benefit and how it's performed using a diagram schematic diagram as you see on this video. So you can use a lot of different instruments. I start with a piezo doing my corticotomies because it's more delicate, and then I continue with a a surgical oscillating saw, and then I do my final osteotomy completion with a series of different osteotomes. Once you do the osteotomies, the most important thing before fixating the two proximal and the distal segments is to place the condyle to the desired place. This is the most important thing in a mandibular osteotomy. You have to do you have to place the temporomandibular joint to the CR, centric relation position. Otherwise, you will always end up with, not always, but you will most likely end up with a relapse on the long run. Okay, so while pushing this proximal segment further back and up, you have to put your finger or your assistant's finger to the inferior mandible and to angulate this inferior border. This is to see if these inferior borders match. This is very important because when you're doing the osteotomy, you're looking inside the mouth and you don't know what's going on the inferior of the mandible. So someone needs to check that for you or yourself, okay, before fixating this two segments. And this is what happens if you don't pay attention to it. This patient was operated by a plastic surgeon who obviously did not pay attention to the antegonial notch, and she ended up with a cosmetic defect here, okay? So that's very important. Bilateral sagittal split osteotomy cuts are completed, and then we use a Babcock or a Wolford forceps to fixate the two segments. We have to do this gently, not to over-torque the condyle medially or distally, but to keep this this proximal segment in the CR position before plating or putting screws in. As I mentioned, you can do 3 bicortical screws, which is the most solid occlusion that you will receive at the end. But if you do not do a very good job, then it's very difficult to correct minor problems because of this rigid fixation that these screws supply. And another disadvantage of this is that if you want to get these screws out at some point in life, maybe a couple of years later, it's really difficult to get them out of the bone. So plates are always easier and more easier to apply intraorally without a trocar incision on the skin. Once you plate the maxilla and once you plate the mandible, then your final splint is out and you check the occlusion. And the final occlusion needs to be reproducible. So you check here at the end of the operation if the final occlusion is reproducible, meaning when you do a couple of different times, if you try different times, it's still on with the initial occlusion that you have prepared, okay? So once you're happy with it, the operation ends and you primarily suture the wounds, and then the patient is transferred to the anesthesia team for extubation. So on the first postoperative day, patients should be not severely swollen, okay? So if you pay good attention to all the steps during the procedure, usually they do not overswell, like I see in some of the cases in the Instagram or in social media, where patients are swollen for a couple of weeks, which is so unfortunate for those patients. So this was the results of her on the postoperative 3rd month, looking pretty good. And on the first year, even better, because the soft tissues usually, really, sit to their final position, and usually the end result is visible on the first year in the soft tissues. And she's become a medical doctor now. So this is from her graduation, postoperative third year, and she's very happy with the result. So what's coming up for us in the near future? Well, of course, custom-made plannings and custom-made cutting guides and custom-made plates will be the future of orthognathic dentistry or orthognathic surgery, excuse me. And using these stereographic models, you can prepare the 3D planning of the patients. And once you do the osteotomies, you can place these pre-bent plates to that specific case, and using the cutting guides and the guides that give you the opportunity to place these custom plates as precisely on with the bones. As you see here, with the computer-guided technology, you can go and create custom plates. And thus, this increases the operative time significantly because you won't need any surgical splints by doing this. So you won't need any intermaxillary fixation and just put the plates instead of the surgical splints. So I'll give you a couple of cases at the end of my speech. And I want to show you the outcomes of these patients if you do a single jaw operation or a double jaw operation. For example, these patients, both of these patients are just Le Fort osteotomies, meaning I just advanced their maxillas, and the postoperative results are pretty good in their projections. This patient had a narrow maxilla and a retruded maxilla, so we had to do a two-piece Le Fort 1 osteotomy. So we skipped the SARP operation, and instead of doing a SARP operation and the Le Fort 1 osteotomy, 1 year later, we combined two osteotomies to a single operation, and we were able to widen the maxilla, and also we had to advance the maxilla at the same time. So these were the postoperative results on the 3rd month of this patient, and his facial profile improved significantly. And just for the mandible, you can treat class 2 patients or class 3 patients, sometimes with just a mandibular advancement or a setback. In this case, she needed a mandibular advancement for an open bite and a retrognathia of the mandible, and everything looked pretty good at the end of the procedure. Or if the patient had a slight obstructive sleep apnea, sometimes if the patient does not complain of a severe sleep apnea, only one jaw advancement might sometimes be even enough to overcome the problems of snoring in these patients. But of course, they shouldn't be diagnosed with sleep apnea. Don't get me wrong. These are patients where the lower jaw is retruded, and with the advancement of the mandible, this patient significantly improves the facial lateral profile and the lip incompetency that she has previously. This is a interesting case, where the lower face height is very decreased compared to the upper and mid face. And thus, we had to operate this patient for a double jaw because she also had a asymmetry of both jaws, and she had a very flat mandibular inferior border. So we had to change that and improve the facial profile as well as the lateral profile of the patient. And if you noticed, her nose looks significantly larger to her face preoperatively, but after the operation, her nose does not look as big as it looked preoperatively. So that's also a benefit. Another double jaw case with an asymmetry of the face and with the anterior open bite. Patient was treated, and he's very happy with the end result. Another asymmetry case and advancement of the maxilla and cant correction of the mandible, and everything lines up, and even the hump of the nose is also decreased. This is also a very interesting case. She had this patient has a discrepancy of the maxilla and the mandible. So we had to first do a SRP operation, and then once everything healed, she went on to orthodontics. And at the end of her orthodontic treatment, she had a gummy smile due to the vertical maxillary access. So we moved we moved both of the jaws into the correct anatomical positions, and now this is the end result. And you see how dramatic change she lived after the operations. So in summary, you have to know what you're doing, and if you plan everything accordingly, then everything will be in good manners after this operation. And of course, a good teamwork really matters. And if you have to rely on each person in your team. Thanks to my residents, Kerim and Berker, I'm very lucky to work with these young guys, and they're helping me out in every operation that I do. And in the most difficult times, I can rely on them, and that's very important in gaining a good surgical outcome. So, as I said in the initial slide, we do a life-changing operation for these patients, and we get a happy patients who are beginning a new life, a happy life after these operations. So thank you so much for your kind attention, and to all those who attended the webinar and stayed till the end of the webinar. I would like to thank everyone for their patience, and I would like to pass on the floor now to the organizing committee. Thank you so much, and I'm happy for answering any questions that you have.
Thank you so much for this amazing and interesting lecture, Doctor. And I cannot see any questions in the chat box at the moment, but if you have a question, yeah, they're coming, I guess. Please ask them, and you can raise your hand and ask with your microphone, of course. So there is 2 questions, Doctor. I can read them for you if you want.
Yeah, sure. Go ahead.
Yeah. So the first one is DBS asked, thank you for your time. What is the difference between having 2 surgeries at the same time compared to just one? Expand and advance the maxilla.
So that's a good question, and it depends on time to time and from patient to patient. Some patients do not want to get everything at once because it's a bigger operation, and the complication risks are more in a single operation if you try to do everything in a single operation. So that's a disadvantage. But at the same time, if we do everything at once, it's a huge time consuming. So they save a lot of time. Instead of waiting 6 months to a year, they can get the 2 operations at the same time. So that would be a good benefit for the patient. But everything has its ups and downs, and having 2 operations is also sometimes better because when we do expand the maxilla first, it's easier for the orthodontists to relieve the crowding on the maxillary arches prior to going to the operation. And compared to the single piece Lefort osteotomies, 2-piece and 3-piece Leforts are always more difficult for the surgeon to operate on because it's a more technique sensitive operation, and also the teeth roots can be affected, and some of the teeth on the neighboring lines of the osteotomies may get necrosis or damage because of these osteotomies. So it's a more risky operation than a SRP operation. Those are the main things that I can say.
Thank you so much. And there's another question from Elif Özdemir. She's asking, is Eller-Weiss kinch suture applied in all maxilla surgeries, or is it only applied in some cases?
Well, I think it should be applied in all cases, because when you raise a mucoperiosteal flap, you usually lift off the nasal muscles as well. So if you do an advancement, which you usually do an advancement for the maxilla, I've never seen someone doing a maxillary setback in a left 1 osteotomy, but you can do a segmental osteotomy to anterior segmental osteotomy to set back the anterior maxilla. But in all cases, you still have to put a cinch suture to prevent the widening of the alar bags. So I do the cinch suture for almost every case I operate on for the maxilla.
Thank you. And she also has another question asking, can any operations be performed for the changed soft tissue after orthognathic surgery?
Yes, of course. I mean, facial cosmetic surgery is always on the table. And if the cosmetic results are not as desired as they are planned, you can always go back and correct minor changes, either with using fillers or Botox applications, or doing some cosmetic stuff like V and Y lip plasties to lengthen the upper lip, or do different types of other procedures such as gingivectomies, or lip repositioning techniques to overcome whatever the problem is in the soft tissue. Of course.
Thank you again. And this is all for right now, I guess. And she's saying
I see.
thank you.
Yeah, I see a raising hand over there, but I don't know
Oh,
if
I couldn't see that. Sorry. So if
Yeah, that's me.
Yana.
I think
yeah,
I
no.
raised it. Yes.
Mhm.
Okay.
Thank you, doctor, very much for your lecture. I really liked it since I'm interested in orthodontics, so I really enjoyed your lecture. It was really informative and fruitful. Thank you very much. I would have one question. You mentioned that the contraindication for the orthodontic surgery are patients with dysmorphophobia. I would like to ask, how can we spot these patients? Like, what can be the signs for such a patient?
So you have to listen really carefully to your patient's chief complaints, and your evaluation, clinical evaluation, starts as soon as the patient enters one step into your clinical room. Okay, so this is a good time for you to listen to the patient's expectations, and you have to really try to understand and focus on what the patient really wants. If they're all over the place, if they're mentioning something like an advancement, and then they're talking about asymmetry, and then they're thinking about, oh, I'm not really sure, but I want to get a result. Sometimes patients come up with celebrities photos, like the patient is like 100 pounds with like a very short neck, a very short stature, and then they bring you a thin model's photo, and they say, oh, look, I want to be like this girl. You know, those expectations are not realistic. So you have to really understand that patient won't be happy with whatever you do. And probably another sign that would be evident is these patients getting a lot of prior operations related with other parts of their bodies, or they might have got facial cosmetic procedures, lip fillers, Botox injections, or facelifts, or all sorts of different cosmetic procedures to change their body or posture or facial aspects. So those are signs that you have to be really careful about. And they usually mention those operations, and they say, I underwent this operation, but I wasn't happy with the surgeon because he didn't understand my expectations, this and that. So you have to be really careful about choosing the right patient, or at least you should know where to say no to a patient. Like, you can't do all the operations for a patient only because they want the operation. Okay, of course you will be in the clinical setup in your future careers. You will make money, but just to make money doing operations is not acceptable. So you have to really be confident in the treatment plan that you're offering the patient, because this is not a Lego that you're going to play with. You know, you're dealing with patients, and you're dealing with human beings. So when I plan a case, the first question that I ask myself is, if I were in that patient's situation, would I be getting this operation on myself? Would I be accepting to get this operation done on myself? If the answer is yes, I do the operation. Otherwise, I don't.
Mm-hmm. Okay. Thank you very much for your wise answer. Thank you.
You're very welcome.
And I also have another question, if nobody else has any. So I was wondering,
Sure.
how do we determine if there's a need for the pre-operative orthodontic treatment, or should we when to perform the orthodontic treatment, before or after the orthognathic surgery? Like, what is the main factor playing the role of determining this?
Right, that's a very good question. Thank you for asking that. I didn't want to go into details for those, but in general, most of the time, pre-orthodontic treatment is really desired because it's much easier for the surgeon to put everything together in the operative room if the two arches are well fed by the orthodontist. In the operative room, it's much easier to put the maxilla and the mandible together at the end of the procedure. But sometimes there are limitations to what you can do as an orthodontist. Sometimes the orthodontist says, oh, the occlusion is locked. I can't move the anterior teeth more, or I can't move the upper teeth in a better position than this. So let's do the procedure. Let's do the surgical part first, and then I will continue my orthodontic treatment. So that's something that you and the orthodontist and the patient will decide. Sometimes the patients are, they work in a job that they cannot take too much time off for the surgery later on, or vice versa. Or there may be limitations to their financial status, like their, insurance coverage will be different next year. Those kind of things also affect the decision for this problem. But in general, it's always easier for us to do the pre-orthodontic treatment first and then do the operation.
It basically shortens the surgery time, right? Because it's
right.
Yeah.
Definitely, because it's a more solid occlusion at the end of the procedure.
Yeah, thank you so much. And does anybody else have questions or something to say?
But I don't have a question, but I have a comment.
Yeah, of course.
Thank you so
Sure.
much, Doctor, for sharing your expertise with us. My heart is warmed when I'm trying to read now the feedback form, and the feedback of the attendees is very nice. So I only wanted to thank you so much, because this feedback, it's for you, it's not for us. It's your time, it's your expertise, it's your experience that you wanted to help dental students to get inspired by such an amazing professor as you. So on behalf of everyone, I would like to thank you so much. And of course, I will be sharing with you some of the feedback comments, because it's very, very heartwarming. Thank you so much.
I would like to thank everyone attending the webinar also. And it's the best thing to hear as a professor from young colleagues. And I hope if this webinar gave you at least a few new information and led you to think about these operations in a different point of view, then I think the aim of the webinar is accomplished on my side.
Yeah, I want to thank you on behalf of IADS and all my colleagues and all my friends here that you saved some time for us and joined us and gave us this amazing lecture today. Thank you again.
My pleasure.
Thank you, doctor, and hope to see you.
Yeah,
Thank
hopefully
you.
meet again in the upcoming event, doctor. Have a wonderful
Bye.
evening. Thank you.
Have a wonderful
Bye.
evening. Goodbye.
You too. Take care.